flip down radiologist.
Okay, can you see my screen?
Yes.
Okay. So this was a 30-something-year-old patient who came in with symptoms of right inguinal hernia, which is the obvious finding, but then there was more to it. And if any of the residents want to speak up or put it in the chat box, that's fine. If not, if you're shy, I can just walk you through it. So these are just the relevant sequences I'm scrolling through. Clearly, he was uncomfortable, so he was moving.
Amanda in the chat was saying swirling in the mesentery.
Yes, good.
Can you show us the coronal? And
Yeah.
like, is it just inflammation or is there soft tissue? Like, is there a liposarcoma?
No, so all this was inflammation. So big inguinal hernia, but lots of mesenteric swirling. I think the swirling was actually best seen on axials. So I'll go back up. So through these images, like here's where that swirling is. So I think this was just a very big inguinal hernia which dragged all the mesenteric fat down within it and created a lot of mesenteric congestion. And at surgery, they took him emergently to surgery. They found that this was twisted 3 to 4 times over itself. And there was secondary inflammation in the appendix as well, which we can see here. So as many inguinal hernias as we see, I've not seen some of like this type of complication where there is a sort of like a volvulus of just the mesenteric fat and emergence.
Yeah, that's really impressive. Is there
Yeah.
also a vein that's thrombosed with it? Like, is the...
I couldn't tell, Aarti. I just thought more of it was congestion. They found significant.
You see how like there's like a linear,
Yeah.
if you scroll the other way. More on the coronal, but anyway,
Coronal?
I was just wondering if that was contributing to the
Don't know, but at surgery they did say that they found a lot of dusky looking areas in the mesentery and they removed some of the fat because it was all like fat necrosis type. So yeah, somewhat unusual complication of
Great
a
job,
common.
Amanda. Great.
Yeah, great job
Yeah,
picking
good
that.
job.
Okay. So this was a young patient who came in with history of left-sided testicular pain, scrotal fullness, and discomfort. And they did a chest, abdomen, pelvis angiogram. Not sure why, but anyway, it's for the good eventually. But these are the arterial phase images, and I'll show you. They didn't go all the way through the testicles on this, even though that was kind of what we were looking for, but on the venous phase they did. So here's the venous phase. And I'll come back to relevant images, but I just wanted to show you that there was nothing wrong with the testicles. Because in young patients with scrotal pain, dragging sensation, etc., some things to exclude would be torsion, testicular mass, large hydroceles, big inguinal hernias with nerve compression, and then you would have to look for associated lymphadenopathy and whatnot. But this was an interesting finding, and I'll stop at the relevant image because this was a hard diagnosis. So what do we think of this image? Just look at the vasculature and see if something looks abnormal on these few images. And how would that connect to the left testicle? Aarti can help.
I'm seeing some compression of the left renal vein and then like a dilated paravertebral vein going posteriorly. Normally though, I then, like if I'm thinking about Nutcracker syndrome, I try to see if there's a delayed nephrogram on the left, and then if there are dilated gonadal vessels. And then the other thing is like, do they have flank pain and hematuria? Because I do think that we can often see this kind of kinking, but we don't necessarily call it unless there's also clinical correlation.
Correct. So other than the testicular fullness and pain, he really didn't have any other symptoms. So no hematuria. They did do a UA. All we saw was also this collateral or paravertebral vein, no gonadal vein to help us either. In females, this would present like pelvic congestion syndrome. But like Aarti said, there's a very narrow caliber of the renal vein, just as it courses between the aorta and the SMA here, with a dilated, upstream dilated left renal vein. And on the sagittals, it's nicely seen. So this aortomesenteric angle, which should normally be in the range of 35 to 60 degrees, is very, very narrow here. So it's a very narrow aortomesenteric angle. So this was consistent with what's called an anterior nutcracker. So the posterior variant is when a retroaortic left renal vein gets caught up between the vertebral body and the aorta. This is an anterior variant of the same thing. So because he was symptomatic, a few weeks after the CT, he actually underwent a venous transposition. So what they did was they took 5 centimeters of the deep femoral vein from the thigh. They disconnected this renal vein. They used that as a graft and patched it directly to the IVC. So few things to remember, like looking at his body habitus. This is something apparently we see in a lot of low BMI patients because there's not enough fat to keep up that aortomesenteric angle elevated, or some kind of congenital ptosis of the kidneys where the kidneys tend to fall posteriorly and drag the vasculature along with them. But this is something to include in our search pattern. We often look at the celiac for the median arcuate and look at that carefully, but I personally have not seen nor measured that many aortomesenteric angles. I just eyeball it. When there are no secondary signs like this, it's really helpful to actually go ahead and measure. Had there been a dilated gonadal vein, that would have been easier. But this was a tough case, but good vascular follow-up, and he's doing much better after the venous transposition.
Wow. So even without the dilated gonadal, it was convincing enough, like the symptoms and
Yes,
everything.
his
Yeah.
symptoms were, because they ruled out all other local scrotal pathology.
Yep.
So,
Wow.
yeah.
Cool.
Yes, 60 something. So older patient came in with nausea, vomiting, abdominal pain, and I'll show you portal venous / slightly delayed phase CT images. There are multiple findings, so we can kind of work through them one at a time. Starting with vasculature, what do we think?
SMV thrombosed.
Right.
And then
Big
I'm thinking about an
thrombus.
abscess in the liver, which would
Nice.
go with like a septic pyelephlebitis of the SMV.
Nice. Yes. So almost another like a cluster sign trying to form here in the left lobe, abscesses in the right lobe,
And then the
big
stomach is a
SMV
little
thrombus.
thick. The stomach and duodenum look a little thick.
It does. And then there's this.
Oh,
Yeah,
what is that fluid collection? Is that like a perforated appendix or?
exactly. So that's the appendical lith. And I have a comparison CT to show where that lith looked a little different. So this was 6 months ago when that lith was still there, even though we couldn't see the appendix itself. I think this is the appendix actually. This was a perforated appendicitis, contained perforated appendicitis with massive upstream pyelephlebitis and liver abscess. And the reason I wanted to show this case to residents especially is we get a little caught up or confused thinking, is this some kind of malignancy with necrosis? And that's fair. And is this tumor thrombus in the portal vein? Are these liver metastasis with low density? But I think looking for simple things like that cluster-like appearance, a little bit of halo like edema in the liver. And he had a normal scan less than 6 months ago. Not that colonic mets cannot happen so quickly, but it's easier to tie it together with plus labs. His CEA was actually normal. He had a normal colonoscopy. What was abnormal were all his inflammatory markers, high WBC, high SED rate, CRP, all of which point to an infection. So radiologically, what might look like a different thing clinically can have the other way around. Clinically, what might look like infection radiologically can mimic infection or malignancy. So when this was prelimmed, we had kind of prelimed it as possible malignancy with thrombus and meds. But then when we did the final read, we were like, okay, infection fits much better with the overall
this is a beautiful example of like those three things coming together, like a GI infection, septic thrombus in the vein, and then the abscess. We'll often see the liver abscess, and people won't scrutinize the vasculature as well. Like, so we might miss like a portal or SMV thrombus. And then often the primary infection is already resolved, like diverticulitis, appendicitis. So like 50% of the time, we don't actually find the primary GI infection, but this is a beautiful case where you have all three. It's awesome. So first, I'm going to show you the scout for the CT. And we can actually make the diagnosis or suggest the diagnosis on the scout.
There's like crescentic air in the left upper quadrant.
Okay, that's one finding.
And then there's like mass. There's something centrally that's just like there's no gas. Like
exactly,
a mass
exactly
or something.
Right. Displacing the gas, and there's something central here. And then there's a tube here.
Oh, nice.
Cocoon.
A what?
Abdominal cocoon.
Okay, from what?
PD. Some catheter is there, right? Isn't that a catheter?
Yes. Exactly. So I'm going to go to the CT now. Actually, I'll go to the axial first. You can see that there's this fluid collection.
It's like a giant CSF-oma.
Yes. So here is our VP shunt coiled, and I think it terminates somewhere here in the pelvis. And we've got this loculated ascites. So this is a CSF-oma. So just a giant loculated collection from CSF building up. These are thought to, be pretty rare for patients with VP shunts. They happen in 2 to 3% of cases. It's usually either due to chronic infection, adhesions in the abdomen, or protein in the CSF that lead to this. And then they treat it by draining. So draining this CSF fluid. Sometimes they actually have to like sort of surgically remove the edges of this cavity, or it'll keep recurring. So this is our post drain. We've put in a pigtail catheter, and they've removed the VP shunt, and the CSF-oma has resolved. There's a little bit of residual fluid here, but yeah, good job.
So what do you think about this? And then these are the post cons, subtraction. And then here's diffusion. So here's your ADC. And then your DWY is here. So
can you scroll through it on the axial T2?
Axial T2, yeah. Hold on. Axial T2. Here is axial T2.
Okay, so it's a big heterogeneous mass that seems to be centered in the cervix with T2 dark areas, T2 intermediate areas, areas of restricted diffusion, T2 bright areas.
Well, the cervix is here, so posterior.
Oh.
So there's a cervix.
So is it like a pedunculated thing coming off the posterior uterus?
Uterus, yeah. It does have mass effect on the cervix, and it kind of elongates it.
It's pretty well circumscribed. So I'm thinking a large pedunculated fibroid.
And then here's your DWI.
You're going to try to convince me it's a leiomyosarcoma.
No, I know this is just, it's just learning, right? Like, I mean,
okay. So those really dark areas, what are they measuring in the ADC? Less
Like,
than.
let's say, I don't know, here, I don't know. Where do we look at that? I guess a good one. Okay. Okay, let's just look at a few. So the ADC has to be at least like, or sorry, the ROI has to be at least 25, right? Millimeters. So this one is 924. Does this one count? Let me see. I don't know if this counts.
But that's so T2 dark. That's more fibroidous.
So can you definitely, so our gynecologists, if we can't definitely say it's benign, like they treat it like an LMS, like it could be LMS. So would you say call this benign and not say cannot exclude LMS? And
I'd
that's
say
where I
favored to
struggle.
be a fibroid.
What?
I would say favored to be a fibroid. What Nicole recently said at SAR was like, they won't just do, I guess they'll change their myomectomy approach, I guess.
Favored to be a fibroid, and you wouldn't mention LMS at all.
No.
Interesting.
Nelly, is there any hemorrhage?
Let me flip the T1. No.
It's a little big and ugly. I would say cannot exclude leiomyosarc.
Is Kater on? Did I hear a guy earlier?
Yes, he's here.
What would you say, Kater?
I said mixed Mullerian tumor is what I wrote in the chat.
Oh, sorry, I didn't look at the chat. Mixed Mullerian tumor. What is that?
Mixed Mullerian tumor,
but the sarcoma should have some irregular capsule.
Yeah, initially I thought it was that because it looked like it was coming directly from the cervix.
Oh,
mixed
yeah.
Mullerian tumor is now called carcinosarcoma, right?
Oh, carcinosarcoma. Got
Which
it.
is thought to be actually an endometrial origin tumor.
Yes. And our path people still call it mixed Mullerian, so that's why and initially on the first scan that's what it looked like, but it does look like a fibroid. I don't think I would have called it malignant.
So this what? This was resected and it was a fibroid.
Yay.
And I mean, if I looked at this, I don't think I would have said cannot exclude LMS. Like I guess I'm like Roopa. Like it.
The two things for me that stick out are that it has really T2 dark areas, like very fibroidy T2 dark areas, right?
Yeah.
And then the other thing is look at the margin. It's like so well marginated, like on the sag. Look how nice and clean that margin is.
Okay. I mean, is that like a high PPV for?
Ill-defined margins is, I think, one of the ancillary type features. It's not in the main algorithm, but that is like Roopa said, like
irregular margins.
Irregular margins, hemorrhagic necrosis. Those are some of the more ancillary features. But
and so your assessment is primarily then T2. Okay, I'm going to show you another case. Okay, let me share my screen. This one I don't have ADC because it was a study that was done years ago. And ADC, I guess, wasn't part of the protocol then. Okay, so how about this one? I just have the contrast and T2.
And do you have the pre? Like, is there hemorrhage?
Pre, I do have the pre's.
Okay.
Here's your pre, and then here's your post. It's enhancing. Here's another post. Delayed. Let me go back to the T2. Here's your axial. Like I said, I don't have diffusion.
This one looks a little weirder to me, but doesn't actually look like an LMS because it's not heterogeneous with necrosis, hemorrhage, ill-defined margins. It looks more like a really densely cellular solid thing.
Roopa,
So
what
I'm
would you
still
say?
favoring a fibroid.
This one has more regular margins, right? Nelly?
Has more regular margins?
That's what it looks like to me. Compared
Like
to the
lobulated?
previous one. Yeah.
So you're saying this is a fibroid?
Well, based on the last one, I thought was not
I
going
have
to be a
these are
fibroid.
all I have like these cases I'm showing are all pathologically proven. So I know what the answer is. And while you share your thoughts, I'm going to show you a third case. So you're saying it's fibroid? Or sorry, what were you saying about that case?
I just thought the margins looked more regular based on. I don't know what to say about the rest of the scan, but at least the margins looked more regular to me than the previous one.
I'm still favoring fibroid.
Okay. Kedar, do you have an opinion?
Could you show the sagittal again, please, if you don't mind?
After this case.
Okay.
Sorry, I went. And this is the third case. Here's your T2. I have path for both, and I'll share it with you, and we'll look back at the sagittal on the other one. Okay, here's your. I don't have diffusion on this either. Here's your pre.
I
Here's.
feel like not having diffusion is really hampering us.
It does, and sorry, these are like old protocols,
I feel like you're
so
just torturing us.
I think the diffusions helps for sure, like, but I think, I mean, what you were saying, right, at the beginning, it's like the T2 is what you were leaning on quite a bit.
Yeah. This one actually,
So
that post contrast, so there's a very T2 dark area there, but that post contrast, like most of it is not enhancing, right? So to me, this looks like a degenerated fibroid. So yeah, right here. Yeah, this is like, it's like really not enhancing.
what do you think, like, about the T2 and you said the margins before, you said it was very, like, circumscribed or something earlier.
This one, the margins to me actually look more irregular.
Agreed, Aarti. Yes.
That's why I said I didn't mind.
But this one, the post contrast to me suggests that it's like very degenerated. So like a
Yeah, there's no enhancement.
Yeah, not much.
What about an adenomyoma that's degenerated?
Yeah, I guess, I don't know. So you would say benign.
Yes.
This was a
Yes.
leiomyosarcoma.
Ugh,
The one before was a leiomyomatosis.
fibroid.
Yes. And I'll bring up the sagittal, Kedar. I know you're asking for that. And I think that, like, for me, the takeaway message is, like, for these, if it's not typical, you just you just can't. It's not, there's nothing. I don't think the margins is, I mean, you can suggest,
But
but
this
none of
third
it is
one, the
definitive.
margins were more irregular.
Yeah, I heard. Yeah, you and Rupert did mention that. Here's the sagittal on the second case, Kedar.
And this one turned out to be a fibroid, you're saying?
Yep.
Yep.
See, Nelly, compared to the third one, this is what I was saying, these margins are smoother, right?
Yeah.
Especially on
margins
the,
are what?
the
Sorry.
smooth at the fundus.
They're what?
They're smooth.
Oh, smooth. Sorry.
Yes, sorry, it's my accent.
No, it's me. Well, Aarti understood it, so it's me. Oh, they're smooth. Okay, got it. So maybe it's, and then I have this case. I guess I mean I have a feeling I know what you're gonna say. This is a consult.
I don't know. Now this one looks just like the second one.
Like this doesn't look smooth, is it? I don't know. This is a consult. I don't have. surgical path.
You have diffusion?
Yes. It restricts.
T1?
Yes, I have T1 too.
So much restriction.
Yeah, this one looks cellular, Nelly.
Yes,
you say
this
it's
I
fibroid.
was just gonna say it looks like a
Very
cellular.
cellular.
Like, would you say it's benign or like cannot rule out LMS?
Cannot rule out LMS based on diffusion.
Yeah.
But is there
What
any
was it?
ADC, any
Some
ADC that was really low?
Yeah. It was under 900.
Mm.
I think there's one here. So I'm trying to get the 25. You have to get the 25 thingy. Yeah, so this one's 868. And here's the post-con. So it's all enhancing. So cannot rule out LMS. Is that the consensus?
For this, yes.
Got it. Okay. Consult. This is a consult. I don't know.
Let us know.
Are we going to make LMS RADs soon?
I
We're
don't
gonna get
know.
LMS
I think it's
rats.
still, I think
don't
it's
know.
Like
still
BIRADs, LIRADs, PIRADs?
No idea.
the one that was the biopsy proven LMS. Now that in retrospect I'm thinking about it, like I was saying, oh, it's so non-enhancing. It's a fibroid, like a degenerating fibroid, but maybe it's just like that was the red flag, is that like it's so necrotic, it's so like aggressive that it's outgrown its middle blood supply. But I don't know.
Yeah, I don't know either. I don't know. I mean, I feel like the more I do this, the more I feel comfortable saying I don't know.
Okay, I have a case.
Like, there's just no way to say cannot exclude LMS, and that's what our gynecologist wants to hear, right? If the minute you say cannot rule out, then it's like they treat it as such. Yeah.
Okay, I have a renal tumor right here. You can see that it has a little like exophytic from the kidney. And it looks like this on T2. And actually we're going to do the clear cell likelihood score here if you guys want to.
Do you have the arterial? I mean, I guess you'll go through that. Yeah.
So here's here's arterial.
Looks like a lipid pore amount, but let's see. Oh.
Here is the delayed.
Do we have so wash this out, there's enhancement. Is there a diffusion restriction?
There is. So here it is on the ADC and the DW.
Do we have CT by any chance? Is it like super dense?
We do not have a CT.
Okay.
But I will show you the in and outs. So okay, here's the in and out. So in, out, there was no convincing bulk fat or macroscopic fat or in microscopic fat. So if you're doing the clear cell likelihood score, one of the things you do is look at the enhancement. So Nelly had brought up a lipid poor AML, okay?
Yeah.
So one of the things, one of the reasons I presume that she brought it up is that it looks like it's T2 dark and it was like avidly enhancing. So whenever we see something
And it
T2,
restricts.
and it restricts.
And it has an Ashburn cone sign.
But whenever we see something that's
It's
T2 dark,
heterogeneous.
we think about papillary tumors, but papillary tumors are usually hypoenhancing. So when they're more avidly enhancing, washing out, we also think about fat poor AMLs. And fat poor AMLs can restrict, but also chromophobes can restrict as a lot as well as papillaries. So if we're using do you want me to bring over the clear cell thingy?
Sure.
Okay, here's the chart. So I will just tell you, so this one was hypointense to the renal parenchyma. And we calculated, so I can show you the calculator if you want, but one of the things you have to do is you basically measure the cortex on pre and post. So the cortex went from 165 to 391, and the tumor went from 161 to 263. So you can see that the tumor is actually a lot less enhancing than the cortex. So when we calculated it using the clear cell calculator, it actually only ended up as moderately enhancing. And because of that,
Yeah.
it's hypointense. It did not end up in this intensely enhancing category where we might think about an AML.
AML.
It ended up as moderate and 3. And I actually showed this case to Yvonne, and he said, yeah, this could be a fat poor AML, but I have seen chromophobes look like this, and both of them will have restricted diffusion, so I'd recommend a biopsy. My surgeons said, you know, even if this is an AML, we would resect it because of size. So anything greater than 4 centimeters, we're concerned about bleeding. It did, you know, moderately enhance. So anyway, they ended up resecting it and it came back AML. One counterpoint that Yvonne came up with was that, you know, it is safe to biopsy AMLs, and at his institution, a lot of times they will embolize them. So that's another strategy for, like, you know, the risk of malignance, of rupture or hemorrhage in an AML is to embolize rather than do resection. So I just thought this was a cute case that, like, you know, the clear cell likelihood score thingy did help. We did bring up fat poor AML, but also put chromophobe in the differential. They didn't end up going for biopsy because they said it was too big, and they resected it.
At SAR, Matt Davenport and Stu Silverman gave a workshop and proposing the idea of chirods.
Yeah.
And they said Matt said in his section of the workshop, like, the reason he doesn't really support CCLS is because there's emerging data that suggests it's not just distinguishing clear cell from everything else, non-clear cell. The emerging data suggests it's differentiating aggressive from non-aggressive features. And even the Bosniak classification, right? Like he said, it's not cystic or solid. It's not CCLS or not clear cell. Is it aggressive feature? Does it have an aggressive feature or not aggressive feature? So in their proposed chirods, they have, you know, kind of, you know, it's a 1, 2, 3, 4, 5 Likert scale. And then they go through kind of the features that, you know, raises potential aggressive tumor, like TF3, TF3 mutation is aggressive, sarcomatoid features are aggressive, versus non-aggressive features. So I think that's what the renal work group is going to be primarily focusing on going forward.
But you say sarcomatoid features, I mean, that's like a much, much more aggressive feature. I think CCLS, at least how I'm using it now, is for like small incidental renal masses that don't necessarily have, like, you know, really classically aggressive features, but I can use CCLS to help me suggest this could be a fat poor AML, or maybe this could be an oncocytic neoplasm in an older patient, or this could be a papillary neoplasm in an older patient, and siphon more people to active surveillance. One of the presentations I saw at SAR was like talking about active surveillance by Santhish from Toronto, and he said that only 5% of people who are eligible for active surveillance are actually undergoing active surveillance. So I do think there's a lot of room, especially in older patients, where we're finding a lot more of these smaller incidental masses, to try to stratify something before they, you know, have like obviously aggressive features, I guess.
I mean, I agree. I think CCLS it's fine because there's nothing better right now. And I guess the chirods, the attempt is to make it better. So build on some of the work with CCLS and merge, you know, kind of have a unifying classification, right? So not a separate Bosniak renal cystic mass, one for solid renal mass, but rather put them have a unifying theme, then looks at specific features that separates the aggressive from the non-aggressive.
Cool. It's a quick one. This patient has a lot of things going on. They had a liver transplant, they have a hematoma, they've got bile injury, whatever. But they also have a renal transplant. And I was told they had a liver and renal transplant. So I was like looking through, I was going down to the pelvis and checking out the renal transplant. And I couldn't find it. And I was like, maybe it's very atrophic. Maybe it was removed. Couldn't find any evidence that it had been removed. So what do you guys think? Hello?
Hey, we're trying to figure out where this transplant might be.
It is that one.
Which one?
Right lower quadrant? Right, like right mid abdomen.
Right there?
Mm.
Nope. Bowel.
Like near the soul.
Is it not in the abdomen at all? That would be funny.
Wait,
Is it
where
in the
else did they put
hepatic?
them?
Well, is it near the hepatic hilum? Or is that all just hematoma?
Is
That's
it not in the
hematoma.
same place where the native kidney is?
Oh, Tarun is saying, is it not in the same place as where the native kidney would be?
Yes. So this is the renal
Because it's too big
transplant.
for a atrophied kidney.
Yes. So this is the
Compared to the
atrophic
other side, yeah.
kidney, and then this is the
Yeah.
renal transplant. So I had never
Nice.
seen this. And so this is what's called like an allotropic renal transplant, where you put it in the place of the normal kidney. And in this particular patient, the reason they did that is that they were already doing a liver transplant, and they decided to put the kidney in. I couldn't get more information about why they did this, because in the literature, when I look it up online, it basically says you only do this when there's some contraindication in the pelvis. So if there was like a prior renal transplant, like if both, areas in the pelvis were occupied by other things, or if there's very severe calcification of the external iliac arteries, which we don't have here, that's when they do this, or if there's like dense adhesions. But so normally they don't do this, but occasionally they do. And in this patient, they did. And I guess there's some clues, like we've got some sutures and stuff here, and it looks very different than the other kidney. But yeah, that was the renal transplant. And the other reason they don't do it is actually, I guess, this kind of retroperitoneal approach is much more complicated. And it's much more complicated to sew it into the retroperitoneal structures than when you use this extraperitoneal pelvic approach. So it takes like a lot more expertise. And then when they do it, they usually put it in the left side because like it has that longer, vascular conduit and stuff. But yeah, so anyway, this was just an interesting orthotopic renal transplant. Okay, so this is a reconstruction from a PET CT. But do you guys see anything in the right abdomen?
Oh, migrated IUD. Lippy's loop.
Yeah. So this is a
Cute.
Lippy's loop, which has migrated out of the uterus. So this was like a very old IUD used in the past. It has this loop-like configuration. I've seen a bunch of these retained in patients, older patients, like in their 70s, one of which was affiliated with a cancer, but I couldn't really find good data that like they definitely cause cancer if you don't remove them. I found a bunch of papers from the 70s that talked about extruded Lippy loops, Lippy's loops. They usually get extruded. I'll show you the axial, but they usually get extruded when you during placement, just like any other IUD that gets extruded. Here it is in the abdomen. This is actually an older patient. They've just left it here. It was not FDG avid. It was just sitting there. And actually now, like just looking at the configuration, I could see that this seems like it would be less likely to erode into bowel than the like normal like T-shaped IUDs that we use now that have the more like pointy ends. Since this one has all these like soft, curved ends, maybe it's a little safer, but they're just leaving this one in place for now. So.
Wait, so this patient came in with elevated LFTs. Here are the MR. Post contrast.
I see like smooth thickening and obstruction of this distal, mid to distal CBD.
Yes. Like, and there's the thickening and enhancement right here.
Yeah. It's a little weird for cholangio. So smooth and
And
concentric.
then here's the MRCP.
Ooh. Well, I mean, that has to be, and there's a little bit of pancreatic ductal dilation. Can you show me the pancreas?
Yeah.
Like, I just want to make sure there's
You
no
want the
pancreatic
P2?
abnormality to suggest IgG4. Ooh, the pancreas totally looks abnormal. It's sausagey with like beating of the duct. So this is IgG4.
Yes, that's what it was. And patient got
And look at that
steroids.
like hypoenhancing halo.
Oh, yes. This one has a nice halo. 1 second, let me pull it up. Oh, wait, that's not the one.
It was like a T2 dark halo.
Yep, right there.
Nice.
Right there. And then patient got treated, and this is the post-treatment MR.
Oh, cool. But look at that beating of the pancreatic duct.
Yeah.
That's
Yeah.
classic.
Oh, is it really?
Yeah.
Tell me more.
It's you sort of get like a sclerosing cholangitis of your bile ducts, but also
Yeah.
like a sclerosing ductitis of your pancreatic duct. So whenever you see your pancreatic duct like come and go, beaded kind
Yeah.
of, and you don't like, it's not like the classic chronic pancreatitis picture, always think about IgG4. And then if you have a
This is
weird biliary
post-treatment.
thing,
The pre-treatment, the pancreatic duct looked like this. It was like, so it was just really diminutive because of all the edema.
but on the T2 axial, I saw it kind of coming and going. Right? Do you see it? Like it's coming and
Yeah,
going.
like here, like
Yeah,
this one's going.
like it
then
comes
here's
and then it
coming.
disappears and then it comes back.
Oh, I see what you're saying.
That's what I mean by beating. Yeah. I don't know if this will help you, but Yvonne told me that there's this river in Spain that goes like above ground and then below ground and above ground, and it's called the Odiana River or something. And so he always wanted to call this the Odiana sign. And it always helps me remember it for some reason. Like, oh, that looks like a river that's coming and going.
That's awesome.
Yeah. So, but also another thing is if you have like a weird biliary thing, if it's IgG4, 92% of them will also have a pancreatic abnormality. So if you have the two together, always think about IgG4.
Excellent.
Okay. Have a good day, guys. Bye.
Thanks. Have a good day.